I guess we'll have a few stragglers coming in, and they can join in the talk as we move along. So we had a not so much an interesting case over here at our hospital, but something very relevant to the field of cardio-oncology. We had a young lady get hospitalized. Let me see if I can scroll through her. The topic is 86-year-old female with breast cancer who had prior chemo radiation and was involved in a trial using COX-2 inhibitors. And she was admitted with angina and heart failure just recently, a few weeks ago. We saw her on the 12th of July. She had been complaining. She'd been fairly active female without much in the way of symptoms, and we'll get into her past medical history. But she'd been having 2 weeks of intermittent squeezing sensation below her breast. Thought at one point that she was wearing a tight bra, and she looked down, and obviously she wasn't wearing a bra. These symptoms were associated with lack of energy, shortness of breath, and she'd been starting to have some hiccups, and thought that she needed to get attention. Things were getting a little worse, and decided to present to the hospital that day when she was having symptoms that were longer lasting. She's very active and does water aerobics twice a week, denied any symptoms prior to this hospitalization, and didn't have any other associated symptoms. So a little bit of brief about her history. She was diagnosed with breast cancer in 2005. She underwent a lumpectomy, systemic chemotherapy, and radiation therapy. And she was part of a research study where they used Celebrex 400 milligrams twice a day. And this was done at Tampa Moffitt Cancer Center. And she was involved. She was on this medicine for approximately 4 months before it was discontinued from the trial, and we'll get a little bit into that. As far as her cardiac history, she had no heart history up until the midst of the trial, where she had either chest pain or questionable MI, and she had underwent a stent to her LAD during that time. At that time, she also had some dysfunction with her heart, and she didn't know a number. We didn't have records, but she had a pacemaker subsequently to that placed, and it wasn't an ICD, and it wasn't unclear what the indication was for the pacemaker at that time, possibly sick sinus syndrome. A little bit about her past medical history. She has no diabetes, no hypertension, no hyperlipidemia, hysterectomy. She had a father who had heart disease, but not until his 60s, so no early heart disease history. So not a lot of significant risk factors. She drinks a glass of wine a day, scotch before dinner. Her exam at the hospital was essentially, PMI was a little displaced. She had some faint crackles in the base at the time that quickly resolved after some Lasix. She was in no distress, no significant other findings. She had some 2 to 3 out of 6 systolic murmur, best heard at the apex. As far as her labs, she had an elevated BNP that went down after some Lasix. She ruled out for acute coronary syndrome, and these were her medicines on arrival. She was on good medical therapy and started on Lovenox and triaged to be ruled out for ACS. This is her EKG on presentation. Sinus rhythm, pretty typical complete left bundle branch block with left axis and left anterior fascicular block. Her pacemaker was interrogated and completely, for the most part, completely sensing with very few pacing. She had some runs of non-sustained supraventricular tachycardia, but no ventricular tachycardia. And her pacemaker was functioning properly. So we have her echo. Let me see if I can get to it here. And so, I don't know if these images are coming through okay. I'll scroll through them. So as you can see, dilated left ventricle, not squeezing a whole lot. Severely systolic dysfunction, EF around 20-25%. There's some thinning here at the anterior septum with some brightness, possibly consistent with scar. Let's move on to the next one. So dilated left ventricle, moving along here. Dilated left atrium. Let's see if we can get some color here. No significant regurg. Oh, we're freezing up here. Anyhow, let me minimize this here. So obviously her EF is down and she's significantly, get out of here. Exit. Exit here. Close this. I seem to have lost my place here. Apologize, we'll get through. Okay. She had a small pericardial effusion, couldn't get through it. Anyhow, what we decided to do next, I don't know if anybody has any comments, we decided since she had angina and she had some heart failure symptoms that the best thing would probably do to do an invasive strategy, but however, she wasn't going to be transferred to Tampa General where we do most of our interventions, as we suspected she would need some sort of intervention at that time. To do a viability study, and we decided to do a FDG PET viability study. Let me show you the images here. Oops. Yep, this is her cath. How do we get back on here?
What do you mean?
Back to the webinar launch application.
You're in the webinar.
Oh, not the webinar, sorry. Trying to get this image just pulled up, 1 second. All right, so here's our FDG PET images, and as you can see, very nice images. You can see as we move up through the apex to the base, we have a large area in the anterior and septal area all the way to the apex of basically no metabolic uptake consistent with scar and prior infarction. Anterior septum, apex, all the way up, and lateral wall. So left circ, RCA, for the most part viable with left anterior descending. Quantitative analysis, again showing you the same thing, a large area of prior infarction in the LAD territory. And at this point, her EF, after some medical therapy and treatment, had improved quite a bit from 20, I think we got on the echo, 22% to 34%. And let me see if I can show you some of those. And so here's her wall motion. You can see some thickening in the lateral and the inferior wall with relative akinesis in the apex, anterior septum, anterior wall. Okay. get back to my PowerPoint. And so these are the findings that we found on the CT. We found extensive calcium and some mild effusions, pleural effusions, and we decided to take her for cath. And let me pull up these images. And here's a picture of her left circumflex, very large left circumflex territory, without really any significant narrowing. LAD, a little shortened. She's had prior stent in the LAD, as you can see here. And I think for the most part that looked okay as well. A little foreshortened here. As you can see, nice and open, nothing that needed to be fixed. And the right is probably going to be a non-dominant right here. EF, roughly 30-35%, with, looks like the anterior lateral wall is not moving that great, and the apex is not moving that great either. And non-dominant small right coronary. Going back to our presentation. So I don't know if anybody has any comments about this case. Again, nothing needed to be fixed in this lady. I think the most important aspect of all of this is the story of COX-2 inhibitors in this lady. I thought I would go over some of the history related to this. I think is very pertinent to our field, and I think you'll find some interesting aspects to the story of COX-2 inhibitors and how it's come about, and the black box warnings that are out there. I don't know if anybody has any comments.
Perception. I'm sorry, this is David Slosky. Did she receive, I must have missed this, did she receive anthracycline or Herceptin in the past?
So we didn't have any records as to her chemotherapy regimen, and she wasn't sure. The only thing she could tell us was that she did receive some chemotherapy. She was part of a trial that involved Celebrex and
Right.
and one of the anastril, one of the other agents, hormonal nonsteroidal therapy agents, but she couldn't elaborate on which drug regimen. We asked for records. We obviously didn't get them in time. So.
Oh, okay.
Did she have any infarction by the time she had her stents put in there? I mean, was her ventricle normal at that point?
So she did mention that she had some chest pain during that time, and she had a stent placed, and she was told that her heart was a little weak, but it wasn't to the point where she had needed a defibrillator any time during that time, and that she had recovered. Again, we didn't get any records back in time. All we knew was that she had been told around that time she had some sort of injury. We assumed she had an infarction at that time. And her EF was probably mild to moderately reduced, and we didn't have much in the way of records. Well,
I guess originally Dr. Harrison, I guess originally when we saw her on presentation, she had an ejection fraction of 11%, and so we were concerned about whether she had an underlying cardiomyopathy, and we didn't really see segmental left ventricular dysfunction on that initial echo, and so we were thinking that maybe she had a cardiomyopathy from chemotherapy superimposed on coronary artery disease and also left ventricular dysfunction, left bundle branch block, pacer, and so it was very complicated, and apparently there had been some deterioration of her left ventricular dysfunction from her prior echo that had been done by her attending cardiologist, and so that's how we got interested in what's going on with her and wound up doing the PET. We didn't have a generator to do a perfusion study. We don't have a cyclotron. We didn't have a generator, so we said, let's do an FDG study. We did that, and we found that a bunch of muscle was dead, which was the apex and anterior wall. The inferior wall and the lateral wall looked pretty good, so we said, well, maybe that's not moving so well. Maybe it's cardiomyopathy. Maybe it's coronary disease. Let's do a cath. Did the cath. Didn't find any disease in the distribution of any of those vessels, and so concluded that she infarcted her apex, and that was remote. The anterior wall was infarcted as well, it's remote. And then the rest of the heart seemed to be better when we did the FDG ejection fraction as compared to the echo. And so that's where we started, where we were going, trying to figure out whether she had ischemic cardiomyopathy or whether she had a chemotoxic cardiomyopathy or a radiation cardiomyopathy, since she had radiation as well. So there's the interest in what you got to sort out with the history and where that leads that we wanted to present this.
All right. Well, and again, she had significant remodeling of that ventricle, so obviously she most likely took a hit at that time, and her EF has sequentially come down. So I thought that we could talk a little bit about COX-2 inhibitors and where we are today. What's the story with these agents, and just kind of quickly go through the history. And I think I found, just kind of going through this, I found quite a bit of interesting stuff. Just with the, I'm sorry, go ahead. All right. So COX-2 inhibitors, as you know, were obviously the super aspirins. They were invented for prevention of gastric erosion due to the NSAID use, and that was their main claim to fame. And so we know the pathways, and we know that COX-2 blocks predominantly prostaglandins, and in particular prostacyclin, which is a pain receptor. One of the pain hormones that if you block that, you can minimize some of the effects and focus specifically on blocking pain. But we also know that these COX-2, these enzymes that they block are also found in the endothelium, and these prostaglandins also promote vasodilation and anti-platelet aggregation. And so it was suspected for a long time that these agents could cause strokes and heart attacks. And so various trials, and so aspirins we knew that decreased cardiovascular risk, and it was thought that COX-2 inhibitors could have the potential to increase your cardiovascular risk. And so let me guide us through some of the studies that were done briefly and kind of lead you to where we are today. And so these drugs were used and thought, well, if they're good for pain, could they have other uses? And at the same token, we could find what if some of these drugs could cause possible cardiovascular problems. So 8 trials were ongoing during that time when these agents first came out to look for other uses. And 6 of them involved Celebrex, various, and some of the other ones were with, and Celebrex, as you know, it's Pfizer, and Vioxx with Merck. And so some of these trials, and this is the trial I believe Our Lady was in, the MA27, which used Celebrex 400 milligrams twice a day versus placebo, in addition to several other agents. Obviously, once the news came out, this agent was stopped in this study, but they were obviously used for to evaluate for recurrence of and prevention of colorectal cancers, Alzheimer's disease, diabetic retinopathy, and so various trials. And what they found and what they quickly came to the conclusion was that these drugs, especially the COX-2 inhibitors, increase your cardiovascular risk. And a meta-analysis was done on all these studies, and they found that as you increase the dose of these COX-2 inhibitors, your cardiovascular risk increases 4-fold. And so 400 twice a day will increase your risk 3 times of having a heart attack. 200 twice a day would double it, and 400 once a day would increase your risk by 10%. And as well as they also found that if you yourself had increased cardiovascular risk, that it would magnify the effects. And so people who are at the highest risk of cardiovascular who also received these drugs had a 4-fold increase. So quickly, as soon as the evidence began to surface that these agents increased cardiovascular risk, Merck voluntarily pulled their Vioxx in the midst of their trial, and similar findings were starting to leak out about Celebrex and some of their other various trials. Quickly, because of pressure, the FDA assembled two advisory committees to come together and determine the fate of these COX-2 inhibitors. And at the time, right before the committee met, Pfizer had developed quickly got together and developed a long-term plan to develop a study that would they would invest $100 million to evaluate the safety of these drugs and compare them to other NSAIDs. And so they presented this at the committee meeting, and the committee, however, they determined that COX-2 inhibitors increased risk of cardiovascular events. However, they voted to keep Celebrex on the market and were split on Vioxx and Bextra. And so they presented this to the FDA as their recommendations. And they also voted, if the drugs were to remain on the market, that a black box warning be placed on COX-2 inhibitors. So just before the FDA met to look over all this recommendations and make a final decision, Pfizer urged, if a black box warning was to be placed on their medication, that it should also be placed on all NSAIDs. And obviously this just kind of reading through all the details, it wasn't clear what the documents they presented as evidence. Obviously, there's some evidence that some NSAIDs may increase your risk in the way of maybe ibuprofen, and then some naproxen may not. And so with all this murking the water, they urged, and obviously the FDA listened. And so it kind of dawned on me that that the FDA and these big companies, pharmaceutical companies, they seem to oftentimes be in bed, much in the way that lobbyists act with Congress. And so the FDA ordered Bextra off the market. Merck actually volunteered to not reintroduce Vioxx at that time, and Celebrex was allowed to remain on the market. However, a black box warning was placed, but not on just COX-2 inhibitors. It was placed on all NSAIDs. And so this is kind of unique. I had no idea. Looking at, if you look at ibuprofen, naproxen, all NSAIDs, they have this warning, not just COX-2 inhibitors. That basically increases your cardiovascular risk, your risk of dying, and perioperative death post-CABG. And so, obviously, a lot of controversy there. I think by murkying the water with all NSAIDs and not just COX-2 inhibitors, you can hurt everybody and not really reduce your sales. And so I don't know if anybody has any comment to that, what you think about that. Well, just moving on. So what about reduction of cancer? What's the evidence out there? So colon cancers have been studied extensively with NSAIDs, especially COX-2 inhibitors, and the Vioxx study, the Celebrex studies, they all showed that that you can prevent polyps from forming and prevent colon cancer. And actually, it's actually one of the indications for these agents. It's actually been indicated. Lung cancer is a study by Harris in Ohio State in 2002 showed a 68 to 70% reduction using NSAIDs, which included ibuprofen and Celebrex for over 2 years at regular dosages. And he also did the same study, a similar study, looking at breast cancer in 2006, and they followed various women from 2003 to 2004 and compared NSAID use, women with breast cancer with women who did not have breast cancer, and they found that with Celebrex, using it for 2 years had a 71% reduction in breast cancer. However, if you use 2 or more pills of aspirin full dose, you had about a 50% reduction in breast cancer recurrence. And if you use ibuprofen or naproxen at regular doses, you would have an even greater 63% reduction. What they did find is that people who used aspirin, baby aspirin, every day, there wasn't any significant reduction. Pretty interesting. And so let's go in back to this study that Pfizer announced and is ongoing. It's called the Precision study, which is a large prospective randomized. They're going to look at over 20,000 patients. And interesting, they're going to look at not only patients who have arthritis, but they're going to look at patients who are at high risk for heart attacks and strokes. So they're actually going to what they're actually doing right now is they have patients who have risk factors and testing and seeing if there's increased risk associated with this. So again, comparing the risk of NSAIDs, including COX-2 inhibitors in patients with arthritis and patients who are established high risk for developing cancers. And so they have to include three of these risk factors to be included in the study: hypertension, hyperlipidemia, premature coronary artery disease, smoker, left ventricular hypertrophy, ankle brachial index less than 0.9, and the history of microalbuminuria. The dosages that will be used, they'll be using Celebrex at 1 to 200 milligrams twice a day, naproxen, ibuprofen, and obviously a PPI for gastric protection. The study is still ongoing, and it's estimated to complete here within the next year or so. So I'd like to kind of throw this back at you and see what you think about this study, if this study is even ethical, what you think we should be doing with our patients. Should we be using COX-2 inhibitors, and sort of outweighing the risk? Obviously, from a cardiac perspective, we want to do everything to minimize our risk to our patients. However, from a cancer risk, we want to try to prevent and any recurrent cancer. So I don't know if anybody has any comments.
Certainly say that we follow in our practice a lady that was less than 40 who didn't have any risk factors for having a cardiac event, who was taking Vioxx, but she wasn't taking it legitimately. She was getting it from someone else, from a friend, and so she didn't have his prescription for Vioxx. She didn't have rheumatoid arthritis or lupus, or she just had some osteoarthritis type symptoms, and took Vioxx for 2 years and had one of these mini infarcts or micro infarcts, where she had a distal LAD apical infarct, no coronary disease, and so we figure it was COX-2 inhibitor related. She had a negative coagulopathy workup and discontinued her borrowed Vioxx, but she didn't have grounds for a lawsuit since she couldn't document that she got a prescription for Vioxx. And so we certainly had a lady like that. The numbers you get there for cancer protection are somewhat astounding from Harris's study, with lung cancer prevention increased by 68%. That's huge. I wonder why that hasn't been pursued more, because we're now doing the NIH approach of CT scanning for people who've had over 40-pack years and have quit smoking within the last 13 years. We're doing yearly CT scanning, and the reduction there is 27% in lung cancer, and you've got a study showing that in 2 years the reduction was 68%. That's very interesting. I'd like to get some other people's feed on that. Any comments from Vanderbilt?
Yeah, I mean, it's all very interesting. I don't know. I mean, I think with anything we try to balance the risk of heart disease. I mean, this data is so compelling in many ways, and I'm not sure that it would be interesting to see with her case whether this is reversible off the off the medication. Yeah, I mean, most of the people we see, they have LV dysfunction to begin with, then they develop heart failure. But I think this kind of study is certainly compelling if you're trying to balance the risk of one disease versus the other. I mean, we still don't know. I mean, the truth is she may have had anthracycline and Herceptin earlier, and we're seeing late effects from this that may not have anything to do with the, with the Celebrex except exacerbating the cardiac dysfunction. So there are a couple of unknowns in this case that I would raise.
Certainly in this particular case, I wasn't present at the beginning, but it sounded like there was a thrombus in this lady, and that she, from looking at the CT angiogram, all she has is a stent, and I don't see any other coronary disease anywhere. So I would dare say that it probably was COX-2 inhibitor induced, since there's no real evidence of a lot of coronary disease. She's got some cardiac coronary calcification you can see, but that's about it. I don't see any intraluminal disease to amount to anything there on that lady. So I bet she was on the other side, and she was one of the patients that got some cardiac risk from her drugs. Vioxx was pretty self-evident very early prior to 2004, and you certainly could have made a case of taking it off the market in 2002 and 2003 because of all the evidence. I don't see that Celebrex is any different, other than Merck was more aggressive to get it off the market because of lawsuits, and Pfizer wasn't, and Pfizer was smart enough to throw in all the NSAIDs to join them in companies so they wouldn't be they would be part of a herd rather than singled out.
And certainly this lady had no significant risk factors, and her PET showed a significant infarction in the LAD territory, and we saw some of that scar on her echo. So I think I agree. I think she possibly could have had a Celebrex-induced insult related, and it's possible she also has a mixed component of non-ischemic, probably from chemoradiation as well. I think it's interesting that she. That the whole drug company and pharmaceutical, how things come about, and how some of these people get in bed with each other to try to sort of damp the waters, per se, by putting a label on all NSAIDs to try to minimize a specific damage that one drug versus another drug, and just sort of murk the waters all over. I thought that was kind of interesting.
Yeah. I mean, she's 86 years old. I guess I would be concerned about even enrolling her in the trial to begin with.
Yeah, that's interesting. Dr. McClanahan is online from Moffitt. Is she still online? Maybe she can comment if she's seen any of these cases over there, because it was they were part of the study, and she was part of that study a few years back. The patient was.
I'm not that familiar with this trial, to be honest. I can't say that I've seen any patients since I became an attending that were involved in this. This is the first I've heard of this actual trial. Since it was done in 2005, that was when I started my residency. But it is interesting that this may be something we'll start to ask people more often now that we're seeing them, just to make sure this wasn't something they were part of before.
I wonder if they still have that trial sort of open out there where you still track the patients, because it'd be really interesting to find out what happened to this group long term. You have to keep the records forever, and I don't know if you have any patients that are identified that come in that there's a mark on them that they were part of this trial, that you'll be a little more circumspect when you see them come by.
Yeah, to be honest, because a lot of them are on these more experimental trials where the drug doesn't even have a name. But this is, obviously I think they would have revealed the name in this trial. But again, I can honestly say I don't remember anybody else being on this kind of trial. But I can ask around Moffitt to see if the research department has record of these people, if they're obviously still keeping track of them, or at least have a database with them.
Yeah, if you could look on the MA27, and we'll give you the name of this patient, and you can call and see if she was Celebrex or if she was placebo.
Mm-hmm.
So maybe you could look that up, because they're supposed to keep those records for forever.
So the trial was aspirin Celebrex used on outcomes in postmenopausal breast cancer patients, randomized to adjuvant exemestane or anastrozole. And within 4 months, as soon as the news surfaced that Celebrex and Vioxx had posed increased risk, they promptly, obviously, dropped the Celebrex from the trial. And I didn't see much in the way of results as far as cardiovascular outcomes once they dropped that part.
Oh, that's interesting. Is Dan online? Dan, do you have anything to show today?
I don't think he's there, Eric.
No, he's not. He's not listed.
Okay, Dan has attending rounds, so he was going to be late.
But I think from a clinical view, I mean, we have patients call all the time that want to take NSAIDs. I mean, the issue is short-term or long-term, and I think we just have to be very, vigilant about identifying their risk as a cardiologist. And I mean, in short-term, there's probably not, a great deal of problem, but longer-term, it becomes a significant concern. I don't think we know that it's higher risk, but I don't know that you can predict in any one individual patient. But I become very concerned about long-term effects of these drugs.
So what do you tell people with 40-year smoking history who'd like to prevent lung cancer, who don't have any known cardiovascular disease? What do you tell those folks?
Well, I certainly would work them up for cardiovascular. I mean, I would work them up, and then follow them closely. I think if that data is really supportable, then and they're high risk for lung cancer, I think that's reasonable. I mean,
so if you work them up, we're talking about prevention. Would you consider, if they didn't have coronary artery disease and vascular disease, and you did a comprehensive workup, would you consider putting them on Celebrex or an NSAID to prevent lung cancer?
Yeah, again, I don't know that data. I'd have to review that data to see how compelling it was and talk to the oncologist and that sort of thing. And it also depends on, I mean, the data he showed, there were a number of NSAIDs that were effective. I mean, there may be NSAIDs that have lower risk potentially of heart failure or cardiovascular disease. I don't think we know, but I think it would deserve a conversation, with the oncologist.
How about 2 aspirins a week, 325 milligrams, to prevent breast cancer in somebody with a family history?
Yeah, that's very reasonable. I mean, we all see people taking aspirin just because they think it works for something. So a couple of aspirin a week is probably much more reasonable.
There's certainly a lot of ladies that are at risk of breast cancer. If you could drop that by half, that's pretty incredible.
Right.
Okay, well, I think that's all we really have today. It certainly has raised a lot of questions about the relative risk of thrombosis, cardiac problems versus cancer protection. I think it's very interesting. I think we'll review the article by Harris, and we'll also look at the breast cancer article with aspirin and talk to our oncology colleagues to see what kind of insight they have on that. That's very, very interesting stuff.
Yeah, Dr. Morales, do you have those references, or can you send them to us, or how can we, the references you quoted?
Yeah, I wonder if you could pull those and send us, the connection that we can connect on the net on those.
Sure, absolutely. I can do that. I can put it in a folder and just zip it to everybody. That'll be fine.
Oh, that'd be great. Very good. That's a great job. Thank you very much.
Thank you.
Okay.
Thank you, Dr. Morales. That was fantastic. We enjoyed it very much.
Great. Thank you very much. Y'all have a good day.
All right. Bye-bye.